We need to look at, obviously, the evidence first, but also, do we have providers that are practicing the evidence today? And that's a huge question. Who are your providers, and who are our clients' providers? Because I'm sure some of you are doulas as well. That we want to make sure that they're following those practices, and also care about what you think. What are your values? What are your preferences? What are your ideals? The issue comes into play here when the evidence-based care model is the gold standard in medicine. Everybody talks about it, everybody suggests it, but the problem is there aren't a lot of people actually practicing it. There'll be folks that'll tell you that they're going into evidence-based birth care, but honestly, their models are about 15 to 20 years old. So they're really not giving you up-to-date evidence. They're probably giving you routine information, stuff that they're seeing in their own practice anecdotally, and not really kind of applying your needs and your preferences. So why is all of that important? Because when we talk about due dates, there's a lot of different evidence that suggests that we really shouldn't be going and making decisions based on a due date. So today I want to describe the risks of going past your due date, the evidence on the benefits and risks of induction versus just waiting for labor, describing the pros and cons of early induction versus expected management care, and definitely this for advanced maternal age, meaning anyone over the age of 35. So how do we calculate due dates? If you guys have ever walked into your OB or your midwife's office and they've ever showed you this little wheel and had this discussion about when was your last menstrual period, that is based on information from the 1700s. That has not been updated since then. There's LMP refers to last menstrual period. And Nagelli's rule is that gestation is going to be about 40 weeks. And that's not necessarily accurate. What might be a little bit more accurate is to look at ultrasound data, but even there are some kind of issues with that, because ultrasound data is really only good up until the first 20 weeks of gestation to determine actual gestation time periods. Because past 20 weeks, the fetuses start to grow in ways that are genetically different for every individual. And so that time period and that calculation is going to be off. So to talk about changing your due date after 20 weeks because of an ultrasound is incorrect. Why is this an issue? The biggest issue is because most women are kind of forced into inductions as a result of their estimated due dates. So inductions for non-medical reasons have been literally on the rise in the US and around the world over the last 30 years. However, the latest birth certificate data from the US shows that the trends may be leveling off. The overall rate of elective inductions peaked in 2010 and then declined. The decrease was largely driven by fewer elective inductions before 38 weeks of pregnancy. And this decrease was largely given by fewer elective inductions before 38 weeks. Why? More birthing persons started questioning the reasons for induction. I'm sure the majority of you listening are definitely doulas, and I'm sure you're frustrated to hear a client has been offered an elective induction. It's very common for a pregnant woman to be induced because they have reached their estimated due date of 40 weeks. And according to the Listening to Mothers survey, more than 4 out of 10 mothers said that 40 1% of their doctors actually pushed for them to be induced. That is an alarming rate of we have 41% of people being pushed for induction and not allowing their babies to go to term. And the biggest issue here is 44% said that they were induced because their baby was full term and close to their due date. That's just ridiculous. Another 18% said that they were induced because the healthcare provider was concerned that the mother was overdue. And this is again based on this old information of how we're calculating due dates based on last period of menstruation, because you have some people who are looking at the last day that you menstruated and then the first day that you menstruated. So you're looking at a plus or minus of 5 days on average. So the risks of going past the due date, let's just talk about why they're so up in arms about going past your due date. So there are obviously some reasons that we want to be concerned about. So chromial amniocentesis is basically an infection of the membranes. That's one issue. Endometriosis could be another issue. Placental abruption. And you can see there'll be the risks of increases of going past 42 weeks, okay? So when you have this video, you can go back and look at that data. And the rest would be a very common term, preeclampsia and postpartum hemorrhage. So you can see that those are risks. And they're real risks. I'm not making light of them. But we have to put those numbers in perspective. Risks for the mom can be primary cesareans increase, primary cesarean for non-reassuring fetal heart rates, forceps, the use of forceps and vacuum increases, the risks of having 3rd and 4th degree tears increase as well. And there are a few risks to the baby. There's the risk of moderate to thick meconium and in the womb, and more admissions to neonatal intensive care unit, and the risks of having larger birth babies, right? So babies over 9 pounds or more. And one more slide on the risks of babies, having low Apgar scores, low fluid, and growth restriction in utero. These are real, and they're not obviously to be made light of. The other issue is stillbirth. That's another reason that we're pushed to be induced. Specifically, African American women are pushed at a greater rate than any other race or demographic. And those, before we get into that, I want to have a little bit of a scientific discussion about the difference between absolute risk and relative risk. So absolute risk is the risk of something actually happening to you specifically. And relative risk is the risk of something happening to you in comparison to someone else, right? So the relative is comparing you to someone else, and absolute is comparing you to you. Why is that important? Because the information that you hear is always going to be given to you mostly in a very significant relative risk conversation. So to say, well, if you wait to go past 41 weeks, you know, your risk of stillbirth will increase by 50%. And that sounds like a lot, and that's a scare tactic, and that's something that you're definitely going to be like, well, absolutely induce me right now because I don't want that risk. But if you take a step back and look at what the absolute risk is, then you could see that there's a difference between 0.6% in 1,000 people instead of 0.4% in 1,000 people. that risk is still low. If you look at the math, to go from 0.6 to 0.4, yes, that's a 50% increase, but it really should be looking at the absolute risk, right? So you could, if you really are given those numbers, then you can see, wow, you know what, my risk still remains low, even though I'm given this number of a 50% jump or increase. I hope that makes sense. So when we're talking about risk of stillbirth with an increasing gestational age, that's when that relative risk is really important to have an understanding about instead of the absolute risk. So 12% of, there were 12 recent large studies that took a look at the risk of stillbirth during each week. And there was one study in Norway, and there was another study in the US. And I want to look at the study in the US. So if you take a look at the US stillbirth rates at the different weeks of gestation, so you have 37 weeks, and that risk is 0.21 out of 1,000. And if you go to 42 weeks, that risk is 1.08 per 1,000. So yes, the risk increases, but you see how that relative risk isn't as great as someone might have that conversation with you about. To move from 0.1 to 0.2% to 6% would be a 70% increase. But if you still look at those numbers, 0.21 out of 0.61 is still not even a person out of 1,000. Okay. Increase in relative stillbirth rates in the late post-term period, and the absolute risk is very small until about 42 weeks. So that's really what the data shows. So to put it into another perspective, there would need to be 1,476 women electively induced at 41 weeks to prevent one stillbirth or infant death. But so we're overusing induction as a way to save lives or to reduce risks. And induction is completely overused for that purpose. What are the risks for stillbirth? There are many. If you have pre-existing conditions, if you are high risk, the conversation for advanced maternal age is there. There are other different things, right, that are there. Some common sense things, just poor health would give you a higher risk for stillbirth. But the bottom line is that stillbirth, there's really no known cause. So this is why this list of risks are all over the place. I mean, there's so many different things there. And because they're shooting in the dark, basically. So let's look at the data to suggest, should we get early induction, or should we just wait for spontaneous labor to happen, allowing our bodies to actually do exactly what it was intended to do? And where's the data on that? So if we have elective risks, we want, obviously, induction without any medical indication. And when there is no clear evidence that the benefits will outweigh the risks for waiting versus waiting for labor. But there's definitely this little kind of gray zone area here where one of the ACOG members, and when I say ACOG, this is the American College of Obstetrics and Gynecologists, many providers only consider induction elective when it is the healthy woman who's having a singleton and is less than 41 weeks of gestation. Just to yourselves, how many people have you heard who's ever had an induction was actually told that they had to have an induction on an emergency basis. And it's very rare, but the conversation is usually given this hyperbole and this very heightened structure that, oh, if you don't have if you don't get induced now, all of these dangers are going to happen, where obviously that's not the case. And the problem is a lot of the data that's been done and a lot of the tests and the studies that have been used in this particular case, then there's a problem, because what they're doing is they're using one group of women who were electively induced without medical indication, right? Just because, for ha-has. And then there's another group of people who are going into spontaneous labor, like they should, versus those who say, no, I don't want to get induced, but then end up having to be medically induced later on because of issues or complications. So all of this data needs to be collected, but what a lot of the tests are doing are looking only at electively induced without medical indication. So when we're looking at why we need to stop the practice of just randomly making people be induced, we're really looking at the wrong demographic. So I don't know how many are familiar with the ARRIVE study. And what I want to tell you is that there's a lot of data to suggest that a woman needs to be induced at 39 weeks to lower her risk for cesarean. And let's just go backwards a little bit here as to why that's an issue. So when the relative risk is 16% less because of an elective induction, this is what the ARRIVE study kind of given us and told us that 16% of women, 16% are going to be given an induction, and that's going to reduce our cesarean rates. Well, there are many other reasons to do this. You know, we have some other options available for people, but what we see is that continuous support during labor, i.e. doulas, will provide 25% less C-section rates. If we're not doing continuous fetal monitoring, we're going to have a 39% less cesarean rate. If we actually able to frickin' move and walk during labor, or plan a water birth, or do any of those other things, we're going to reduce our cesarean rates by 16%. So this study that came out that we're just really kind of pushing people at 39 weeks to be induced because we're going to reduce cesarean rates is actually erroneous. The pros of induction of 39 weeks. Maybe there are some good things, right? So avoiding potential complications, and this is specific for moms who are high risk. So we don't want to have, you know, if you have hypertension, if you have preeclampsia, if you have the possibility of having a large baby, which means macrosomia. So we can definitely lower that risk for first-time mothers for so-called failed protocols. And there's some people who are just tired of being pregnant and want to end the uncomfortable pregnancy at 39 weeks. But that's not a medical reason to have any kind of induction situation. So what are the cons? Usually there's a higher potential for failed induction that would lead to an unnecessary cesarean section. Inductions take forever. There's a longer time spent in labor. There's also a very medicalized approach, meaning you're going to have a cascade of interventions. So understanding that if I get this one thing, that this next thing is going to happen, and this next thing is going to happen, and this next thing is going to happen. And it just keeps going down the slide that way. Medically induced contractions causes more pain. It's not natural. It's not what your body was meant to feel. And as a result, sometimes you can have rapid contractions. And then we also, for the hospital space, we're not really calculating the cost of having a person in labor that long for induction using the resources. So what's the difference between late and post-term induction versus just waiting to go into labor? There's a meta-analysis, so there's a little bit of data here, right? So there's a Cochrane review and a meta-analysis with 30 randomized control comparisons, right, of induction at or beyond term versus expected management care. That's what EM stands for. And there's a few other tests. There's a HANA post-term test for this trial that's comparing information and data to the ARRIVE trial. From an evidence and a scientific point of view, that data is pretty moderate in terms of quality. So it's not crazy great, but it's not terrible either. So we can take that data and see where we're going to go with it. So in this group analysis, there were no clear differences between timing of induction, right? So less than 41 weeks versus greater than 41 weeks. Or by the state of the cervix that we've seen for perinatal death, stillbirth, or cesareans. What we want to do is say that we really need just some more research on the risk profiles to know who would or would not benefit from scheduled induction of labor. And the optimal time for scheduled induction is still not clear from the research. So although it was moderate, we got a little bit of data from there, but we're not getting exactly any kind of real information. So let's take a look at the HANA post-term study. So there are about 3,400 women who had low risk. Unknown caller. Unknown caller. Who has, apologize, who had low risk, who were low risk, and they were in Canada. And they were assigned either induction at labor or monitoring at 41 weeks. So in that information, around 41 weeks, women were randomly assigned to either be induced or to have fetal expected information. Unknown caller. This is not happening. And then we had, I'm sorry, somebody just keeps calling me and I gotta keep turning this off here. Alrighty, so anyway, the labor was induced within 4 days of entering the study. And if the cervix was not ripened by using a prostaglandin gel, then they would use a maximum dose of the gel every 6 hours. And if that didn't work, then they would give intravenous oxytocin for 12 hours until a woman went into full active labor or her waters broke. Then in the expected management group, we had a person who looked at kick counts daily and non-stress tests 3 times per week. Also looking at the amniotic fluids and would suggest labor to be induced if that non-stress test gave them that less than 3 centimeters deep pocket of amniotic fluid. Also in this test, there were a few mothers that just did not go into labor on their own by 44 weeks. So the study was quite interesting for them to allow and let women go to 44 weeks of gestation. So what did they find? Of that group, in the induction group, 66% of the women were induced, and 34% of them went into labor on their own before induction. And in the expected monitoring group, 33 were induced, and 67% went into induction on their own, went into labor on their own. And if you look at these two groups, what we can actually say is that what happens to the woman who was actually induced or actually went into spontaneous labor? Because this data doesn't really indicate that. So let's take a look at these two groups. So the first group was randomly assigned to induction. They actually ended up getting a 21% cesarean rate. The other groups who were randomly assigned to expected management care, meaning sitting on internal fetal monitoring for a very long time, ended up getting 24% rate for cesarean. That's kind of high, right? Why is that? So if you break it down, look at those groups, the induction and fetal monitoring groups, what happened to the first-time mothers who were actually induced? Some of them actually went into spontaneous labor. So that's why we can see a little bit of a difference in that lower cesarean rate for most of the mothers. But the other interesting thing is that the first-time mothers in the monitoring group had an induction, and their cesarean rate got higher and went all the way up to 42%. So inductions aren't actually helping reduce cesarean rates. They're actually increasing them on some levels. That's the biggest takeaway here. And then if you look at a mother who's actually had a baby before, and now she's going to go this induction route or this expected management care, she's going to have a much lower risk of cesarean rate because she has a proven cervix and a proven pelvis, and her body knows what to do already. Why? Several reasons in this case, right? So what do these numbers mean? One, a mom may have developed some medical complications that make a cesarean necessary. Two, fetal testings show that some of the results of the care providers get very, very anxious, and they're so much more likely to recommend a cesarean. So this is really about provider care and who your provider is and how comfortable they are with just waiting for birth to happen. And there are so many providers that actually are not okay with that, and they want to insist on managed care. Is it okay for you to wait on your own? Absolutely. A woman who gets closer to 41 weeks, it's very appropriate for her and her care provider to discuss the benefits and the risks of elective induction and expected management. Most research articles and guidelines say that because there are so many benefits and the risks on both sides, and we have to really evaluate those. And remember, going back to that evidence-based model of care, where we're looking at what the individual woman's values are and what her provider's experience is. If the provider is not experienced in looking at the latest data and the latest evidence, then they're not going to suggest anything outside of the norm or what's protocol or routine. If we're looking at induction at 41 and 42 weeks, so there's some pros. So let's just sum it all up, right? So we can avoid potential complications of prolonged pregnancy. Some of the decreased rates of risk are rare in stillbirth and low APGAR scores. We also have a lower risk of cesarean. But what are the cons? Medically induced contractions, suprauterine hypercontractility, and potential for failed induction leading to preventable cesareans, and that cascade of interventions or that domino effect that you might hear a lot of people talking about. So if we wait, what happens? Spontaneous labor, fewer interventions, avoiding risks of medically induced contractions. There's a lot of just wonderful hormonal benefits to allowing your labor to go naturally. And some of the cons, there's a relative risk of higher stillbirth. Remember, relative, not absolute. So we're not looking at huge, huge numbers here. there's definitely going to be a little more extra fetal monitoring if your provider is nervous about this, letting you be at 41 or 42 weeks. And if you end up asking for induction later, sometimes your cesarean rates will double because of that induction. So I'm sorry, let me go back here to this slide. Some of the best ways for a provider to frame the risk of stillbirth is, again, to look at those numbers, look at the absolute numbers versus the relative risk numbers, to have conversations with you about your goals and to talk about the possible gains and losses there. Offer visuals, right, when needed, and focus on the difference. So I want to put relative risk and absolute risk into perspective for you. So if you look at this graph, this is a graph of 10,000 blocks. And in that 10,000 blocks, the risks of cesarean rates, or I'm sorry, stillbirth rates are 6 out of 10,000. So if we increased that information, if we look at how much induction is actually going to change and make a decision for us, know that our risks are not that great. We're really not that huge. So waiting for the ACOG absolutely recommends that induction of labor should take place between 42 weeks and 6 days, and that induction should happen at 41 weeks. But how rare is this happening? This is latest evidence. This is what the ACOG is recommending. The American College of Obstetrics and Gynecologists are recommending that induction doesn't take place until you're 42 weeks. But we have all of these studies and all of this information that's saying inductions are happening at 39 weeks. Especially if a woman is planning a VBAC and goes post-term, this does not mean that she has to have a repeat cesarean. If you're interested in having a VBAC, you can also go to post-term. So there's a lot of data on that as well. So let's get into a little bit of advanced maternal age. Care providers are really looking at the differences in where everybody is getting pregnant, right? So there's that data right there that's showing you there's this peak at around the group of 25 to 29 years of age. But we're starting to see on the back end that the 35 group to the 39 group is on the rise. And obviously there's a lot of reasons, a lot of good reasons to wait for pregnancy. And sometimes, you know, it's because we have, you know, careers, or we're in newer relationships, or we're getting out of relationships and we're actually, you know, getting new ones and wanting to have a baby. So whatever those reasons are for waiting should not define you as a super high risk individual. So let's look at the data that shows where you are in your relative risk. Now, this looks like a very confusing slide, and I just want to highlight one little point here. Let's go back. So one little point, if you look, this is going to look at women who were less than 35 that are healthy, women who are less than 35 that are unhealthy, and conversely, women who are 40 or older and unhealthy, and others who are healthy. So, excuse me, the dotted lines are the healthy people. And what we see is this risk here at gestation rate. So if you look at the x-axis, we're seeing how many stillborn deaths. And if you look at the x-axis is the gestation weeks. Okay, so that's 20 weeks, and the y-axis is how many stillborn births. And if you look at this data, what we're seeing is the chart shows you that there's the absolute risk for an older mom at 40 plus weeks is 0.21 births out of 1,000. versus 0.7 births out of 1,000 for younger moms at 41 weeks of gestation. So that data doesn't show that there's a huge difference there, right? So similarly, the rate drops if this isn't her first baby. So if in her first premapara, first pregnancy, first birth, the risk is slightly higher. Body hasn't gone through labor yet. But once your body does go through labor and you come back to this the second time around, even it doesn't matter what your age is, your risk is lower. So you would absolutely have the possibility of having a normal pregnancy and a normal birth without risk of increase of stillbirth. So there's another meta-analysis here with the 4 randomized control trials. And one of the recent studies in, for advanced maternal age was done in 2016, and which was great. So we have some realistic, up-to-date data. And this is going to look at inductions versus managed care for birthing persons over 35. What does the study say? Boom, no difference in cesarean rate with induction versus expected management care. No perinatal deaths had occurred out of 2,675 participants. So this looks pretty good. Some of you might be familiar with hearing about this 35-39 trial, where they want women who were over 35 to be induced at 39 weeks. There was a lot of obstetricians who are following this guideline, and the data doesn't suggest that this needs to continue. It was based on very, very weak trials. So when we look at that information, the study should aim to allow women to wait until they're 41 weeks in gestation. We are looking at singleton babies that heard first, no gestational diabetes management, and no IVF in vitro fertilization for donor eggs. So there's a little bit of difference there, right? There's absolutely no cesarean difference in the cesarean rates. There's no difference in maternal complications, birth satisfaction, APGAR scores, newborn interventions, no deaths or no stillbirths. And why is this important? Because when you look at what is going on with current women over the age of 35, they are automatically told that they will need to be induced at 39 weeks. And if we're not seeing any difference between maternal complications or satisfaction or anything happening with the baby's APGARs, why are we making this recommendation to women? The bottom line is we really need to have a conversation about the midwifery-led model of care. This is what's going to get us out of these heavily medicalized spaces. When we remove birth from the hospital spaces, we're going to have better outcomes for all women, and specifically for Black women. The low-risk study for, there are multiple pieces here. We looked at home birth, we looked at freestanding centers, we looked at midwifery units that were alongside hospital spaces. All of this gave information for how that study came about, and the results were beautiful. With midwifery-led situations, we had fewer interventions, fewer cesareans, and very good newborn outcomes for women over 40. In hospital-led situations, we had way more interventions, way more cesareans, and babies needing to go into an NICU. And this is because of the heavily managed care. So where you birth absolutely matters. Your choice of care and your choice of providers matters. Okay, I'm going to open it up for questions. We have about 4 or 5 minutes. If you guys wanted to ask me anything, go for it, or we can move on. Do I hear anything? Hello?
Michelle, good morning. Good morning. There was a question in the chat room.
Oh, I'm sorry. I can't see the questions in the chat room.
I'll read it to you. It says, Crowning Birth says, but Dr. Gabriel Caldwell, your body makes a baby that you can, whoops, what happened to it? Your body makes a baby that you can carry, so there's not really such a thing as a big baby. So when you say large baby, what weight are you referring to?
Okay, so usually, and I agree, your body definitely does exactly what you were designed to do. So big babies usually come into play when a mother is diagnosed with gestational diabetes. That usually is where that happens, because the intrauterine growth can actually kind of go off because of that. But typically what they will do is look at ultrasound information, which you should know is based mostly on erroneous data and kind of standard deviations that are really off. So when you're looking at the growth of your baby's rate, the conversation is that sometimes they're making suggestions that your baby is going to be larger than it actually is, when in fact sometimes you'll get a cesarean and they've told you your baby's going to be 11 pounds and your baby's at 7, right? So a lot of that information is off in terms of larger babies, but you're absolutely right. You're going to make a baby that you're designed to have and that you can push out of your uterus. They're usually not too many issues with bigger babies. I've been at home births where babies were 12 pounds and no tears. So large babies are, just more lovable.
So Michelle, there's another question here. Are there any studies about women ages 50 plus birthing naturally versus medically, or as the term is clinically?
There are some studies with when they would be categorized in the 40 plus group, and we would have to drill down into that data to see where they lie. But we can pull that out. If somebody had a question, I can actually kind of dig into it for them and send them that information personally. But I don't have that here ready for this presentation.
Thank you. Next question. In the hospital and doctor's office, they usually tell the parents that they must deliver by 40 weeks because the baby has had its first poop. This usually scares the mom and they agree to induction. What can we tell them when they tell them that they can wait until 42 weeks? So what can the families tell them or tell the clinicians knowing that they can actually wait till 42 weeks? Or with the meconium in the picture now, can they really wait till 42 weeks?
Okay, my first question is, how do they know that the baby's had its first poop already if the water didn't break? So that's an interesting.
Does that show up all the time on a sonogram? That's very hard to decipher, I would imagine.
Yeah, no, you can't see that usually in an ultrasound, that the baby has had its first poop. And you wouldn't know that unless, again, the water's broken, you saw meconium there in the amniotic fluid. But yes, so what I'm going to have here, Brooke is going to provide all of you some PDFs on the evidence. So all of this stuff that I went over, all of these numbers and everything, you're going to have in your hands. So there's 2 PDF files. There's one for due dates and one for advanced maternal age, and that should show up pretty soon in the chat box for you guys. To have in your, to look at the studies, to talk about the data, to have those conversations with regard to, here's proof that I can wait. Like, look at this study. The study actually says that it's okay for me to wait. So you can go in there with a little bit of backup.
Yeah.
Okay. So I'm getting into, we're at 10:31. So I'm gonna close out the questions so we can get into the next session so we're not behind. And I wanted to thank you guys for your time and your attention. If you are interested in any more research or data, you can definitely find me. This will be, again, in your package on the videos for recording, so you will see that. And hopefully you'll get those PDFs in there as well. And again, thank you guys. Enjoy the rest of the conference.
Yay, Michelle! Woo!
Thanks, Denise, for helping to moderate. And I would like to introduce Miss Camille Adrian, who's going to give you guys a little Reiki after all that damn data that I just gave y'all, okay?